So you can see your pyramidal eminence. And just below medial and inferior, you can see your round window. Super helpful landmark, because sometimes you're doing a surgery on somebody with a lot of inflammatory tissue, or sometimes you're doing surgery on somebody who has otosclerosis, ossification of their inner ear, charge syndrome, all these other things that can obscure or make it difficult to see where your round window was. Knowing where your round window is nice, for particularly for a cochlear implant, because that tells you where your basal turn should be. And technically, if you're opening your round window, you're going to enter scala tympani by definition, which is the ideal placement for a cochlear implant. But this anatomy locks in, and it's always the same on everybody. I want to just talk briefly about opening a facial recess. So most of the time, a facial recess is used for cochlear implant surgery. It can also be used for cholesteatoma. A common misconception is that opening the facial recess will allow you to see the sinus tympani well. That's not true. The sinus tympani is the space, the hollowed out space on the other side of the facial nerve underneath the pyramidal eminence. And so you might be able to see cholesteatoma around a little bit better, but you certainly can't see into the sinus tympani very well, just as a side note. But when you're doing this for cochlear implant surgery or cholesteatoma, there's kind of three or four different ways people open the facial recess, and all of them are okay. Just you have to figure out what you're good at and what you can be safe with. The facial recess is bordered posteriorly and laterally by the facial nerve, anteriorly and medially by the chorda tympani nerve, and then superiorly is the incus buttress. This is a person-made corridor. It's not naturally there. We drill it to create it. Some people it's solid bone. Some people it's hyperpneumatized. When we're talking about the posterior bony ear canal and the facial nerve, I think it's also important to visit this idea that almost every important piece of anatomy becomes plated before you see it. So you'll enter all these air cells around things, but when you get close to any important anatomy, almost always there's a bone plate around it. So the posterior bony ear canal, you can keep removing honeycomb bone until you get a plate. Over the facial nerve, almost always there's a plate of bone over it. The dura, the sigmoid, almost all of these things have that. The facial nerve in particular tends to have a couple of blood vessels over them, and they'll often be a little bit more lateral to it. So you're drilling down, you'll see these blood vessels. You're wondering if it's the facial nerve or not. I would treat it as a facial nerve unless you're very confident, but there are blood vessels that come with them. So getting back to opening the facial recess, the most common way is just to identify the facial nerve definitively. You drill over it with a large diamond. You go back and forth until you see it, and then you can drill down inferiorly and find your chorda tympani nerve, and then that's your corridor. You can open up your facial recess. That is the way to maximally open it. There are some downsides to it. It takes a little bit longer, even if you're very used to doing it, because you're delineating all those structures. You have a slightly higher risk, I think, of a delayed facial nerve paresis, because you're exposing more of the bone. You're a little bit more devascularizing it. And there's a little bit more heat around it because you're drilling around it. I think that risk is low, but I think it is true that it's a little bit higher. And then there's, I think, and I know people will disagree with me, and that's okay, but I think there's a little bit higher risk of injuring it when you're trying to expose the whole thing or see it really well. Most people don't try to uncover it, but you want to identify it. So that's one way. A second way to do it, we don't do this in the US a lot, but actually, and my understanding is in Europe, some people will do this more frequently. You'll actually find the digastric muscle, and you'll follow that forward to the stylomastoid frame and then follow the nerve up, and then I open it up. But that just shows you that the anatomy between the digastric muscle and the stylomastoid frame and in the facial nerve it's a pretty reliable relationship. I don't use that. I don't know anybody that uses it in the United States, but it is a way. Another way to do it is how I do it. I open the recess without trying to find the nerve, but I'm looking out for the nerve. So I'm not doing it blindly, just drilling through it, but I'm trying to go through safely. And I use this general landmark. I use where the incus buttress touches the incus. There's always a white dot there. That's always there. Sometimes it's really prominent, sometimes it's less prominent, but that is always the widest part of the facial recess. It's always in the center of this, equator of the facial recess. If you make an imaginary line from that white dot to the anterior portion of the mastoid tip, it'll always bisect this. In fact, it's just coming out in a paper, but it basically shows anatomically it's very reliable to bisect it. And so I just start drilling in that trajectory, and I keep drilling until I start seeing, I'm drilling through it, and I usually end up seeing the stapes tendon first. And then once I see that, I know exactly where everything is, because I told you that, just like I said, that anatomy is all locked in. I'm always looking for the facial nerve, but I'm always looking out for it so I don't hit it, but I'm never trying to find it directly. Some people will just start drilling back and forth in that area where they think it is, and then if they see the facial nerve, they'll take that as a cue and go anterior to it. All those ways are okay. The principles of facial recess surgery are the following. Before you start opening it, there's something called preparing the facial recess that's often not talked about in textbooks or anatomy dissection atlases, but it's the idea that you want to set yourself up well. And how you do that, you make sure your bony ear canal is thinned well without going through it, but you're down to that bone plate, and you make sure the bone over the facial nerve is lowered to an appropriate level, almost all on one plane. The facial nerve at the second genu is never lateral to the lateral semicircular canal. It basically never is. As you move inferiorly towards the stylomastoid frame, and it can start coming out laterally, everyone's different. Sometimes it's at the same plane, and sometimes it starts working out or coming out more laterally, but you want to lower it to about that level. And then that's what I would call, setting yourself up, preparing for the facial recess. After you've done that, and it's all lowered to a same level and you're ready to start drilling, usually switch from a 3-diamond to a 2-diamond at that point. A 2-diamond will fit through almost every facial recess at the widest part, which is the superior part, and you'll just start going back and forth. Just like any surgery, you want to move with the structures and not against them. So you'll move superior to inferiorly. You want to take broader strokes so the bone has time to cool down in between your strokes. You also have time to see the bone you just removed as you're moving back and forth. Make sure you have constant irrigation. You don't want to be drilling the bone dry. Having irrigation cools the bone, removes bone dust around you, and a millimeter film of water over bone allows you to see through the bone about a millimeter. You can actually see through bone if you have a little bit of fluid over the top of it. You'll see the facial nerve through that. I think those are the primary tenets of drilling the facial recess and different ways to look for it. Dr. Patel, I know that you have a slight variation on some of the things I've said for opening the facial recess. Do you want to talk about how you walk through that with trainees?
Yeah, I think that's a super consistent, super reliable way to do it. I have a preference to see the chorda tympani nerve, and I'll go back just one slide. And the reason for that is I think that by telling, especially when I'm working with trainees, that saying I want to see where the chorda tympani nerve, either in the bone, in the mid portion of the facial recess, or as it articulates with the facial nerve, not removing all the bone off the facial nerve. In fact, not actually removing bone off the chorda either. I think it essentially forces people to lower the bone sufficiently. So if you haven't done that, if you haven't thinned your ear canal enough, you won't see the chorda tympani nerve. And if you haven't lowered the bone on the facial enough to the level of the horizontal canal, then you won't see that articulation either. And so I think it sort of forces you to get down to that plane. And then the other thing that I'll stress is there's sort of a change in angle that happens halfway through the cochlear implant operation. So initially, when you're thinning the ear canal, often you have the patient's head kind of rotated pretty far away from you, or the scope very far down, looking anteriorly, so that you can visualize the ear canal really well and thin that really well. It also allows you to see into the antrum a little further if you have some bony overhang over the incus or whatnot. And then at some point, you sort of have to switch and steepen your angle, where you're starting to look now for that round window. So somewhere, in the process of making that transition, I think people can be looking really far anterior, and then the position of the midpoint of the incus buttress can make you feel like that the recess is more laterally and sort of anteriorly positioned than it should be. And in contrast, if you have your angle a little too steep too early, then that could get you into, sort of posterior to the pyramidal eminence and where the facial nerve is. So just some other things to add. There's, like Dr. Carlson said, there's many different ways to do it. And once you find a safe way, then I think that's fine. But what I wanted to stress here in this section on cochlear implants is where the round window is and that constant relationship between the stapedial tendon, pyramidal eminence, and round window. And the other thing you'll notice, just comparing these two slides, which are the same specimen, are that the round window niche overhang can sometimes be really prominent, and the window can actually be very obliquely positioned to your view. And that can make it seem like the window is going to be way more inferior than it is. But if you stick to that relationship where it's about 2 millimeters from the pyramidal eminence, often you'll discover that just taking the round window niche overhang off will reveal all of the round window membrane. You'll say, oh, it's actually much more superiorly positioned than I thought it would be. The second thing, going back to opening the facial recess, that's important is the more bone that you leave on the facial, that seems like the safer thing to do, but ultimately it can very much create tunnel vision through the facial recess. So you're trying to get light into a 2 millimeter-ish by 4 or 5 millimeter triangular space with a microscope. And everything is line of sight on a microscope. So if you have a lot of bone high over the facial and a lot of bone on the ear canal, that aperture is very narrow. And so lowering those two structures will make the facial recess seem a lot wider than it is. A lot of times somebody will tell me, oh, this is just a narrow facial recess. It's usually not. It usually means that there's just too much bone over the facial or too much bone over the chorda. Going back to cochlear implantation procedures, specifically, the round windows, of course, are our preferred method of entering the scala tympani. But not long ago, almost everybody did it through a separately positioned cochleostomy, which is generally anteriorly and inferiorly positioned from the round window. And why is it anterior and inferior? It's primarily just to get into the scala tympani confidently, as opposed to entering into the scala vestibuli. A cochlear implant will still work in the scala vestibuli, and sometimes you have to do that when the basal turn has partial ossification or fibrosis or involvement of otosclerosis. But ideally, you do want it in the scala tympani for the best hearing outcomes. Much less commonly used would be alternative approaches to the cochlea. In this case, you don't have to do this every time, but we've taken away the ear canal in the specimen so that you can see these structures really well. You can access the scala vestibuli through a transmastoid transfacial recess approach. But just to demonstrate, this is basically where the round window was. The round window membrane's been removed and the scala tympani is seen here. And then as you work anterior a little bit and superiorly, you'll cross the osseous spiral lamina and enter into the scala vestibuli. This provides you with essentially the same length of insertion of the electrode. It's just that you do have to drill a little bit more medial to enter into that separate space. And I've already mentioned a couple of reasons why you have to do that. But ideally, the sort of position A for a CI electrode is in the scala tympani. Even less commonly used, I've never actually done this in anybody, is a second turn insertion. And essentially, if you think about the direction of a cochlear implant electrode as it moves through the cochlea, it gives you an idea of what the position of the cochlea is as you view it through the temporal bone. And remembering that the geniculate ganglion, just superiorly medial to the cochleariform process, is essentially sitting more or less on top of where the cochlea is. That's the direction that the apex goes. And so the second turn of the cochlea can be accessed just inferior to the facial nerve, essentially in front of the oval window, a little bit inferior. This is only to be used really in a case where the basal turn is completely inaccessible. So in theory, if I were to do this on somebody, it would be that I've already drilled out the extent of the basal turn, both scala tympani and vestibuli, and have not been able to place an electrode through there. and then you would go to the second turn. But it's relatively less commonly used. You can place those electrodes anterograde, where it actually goes toward the apex of the cochlea, or retrograde toward the base of the cochlea, depending upon where you think you have the highest chance of getting the array in. There are split electrode arrays where part of it is going through a second turn insertion, part of it maybe through some alternative insertion into the cochlea, either into the basal turn or elsewhere. So that kind of covers cochlear implantation, which is essentially just a limited mastoidectomy and a facial recess approach.